Neither myself nor any other member of the Hub team has any financial disclosures, whether currently nor in the past. So we're going to talk about opioid use disorders and pain. This is a big topic. Sometimes I do this for anesthesia residents at UNM. And this talk sort of gets expanded into a 2-hour, kind of a 2-hour didactic. But here we're sort of going to focus on kind of the nitty gritty of it, the main principles of it, talking about both acute as well as chronic pain. My goal is to kind of cover this topic in the next 20-25 minutes or so. Moving forward, so we're going to summarize the effects of comorbid opioid use disorders as well as chronic pain on the patient's quality of life. I think the one take-home point that I want to make is that second bullet, right? Which is that opioid replacement therapies, medications for opioid use disorders don't preclude the need for effective pain management. And finally, describe and apply strategies how to manage pain in patients on opioid replacement therapies, medications for opioid use disorder. I think that's the one I really want to focus on. Starting with prevalence. So if you look at the studies done in the 21st century, and these are studies looking at percentage of patients who have opioid use disorders who also have chronic pain. You can sort of see that the number has steadily gone up, right? Starting from about 37% to more recently, the study by Dr. Sayre coming out about 3 years ago found that about 64% of patients in that particular study who had opioid use disorders also had underlying chronic pain. So I kind of wanted to focus on that study because I thought it was a really well done study. And where they essentially took over 5,000 adults, all of them had opioid use disorders over a 10-year period, and kind of tried to track the presence or development of chronic pain. And the key point there was that while the relationship is bidirectional, more often than not, it's actually the chronic pain that tends to come first. So chronic pain tends to precede the development of opioid use disorder, which was one of the findings of this particular study. So out of those 5,000 people, about a third had no pain, had opioid use disorder alone. However, for another 10%, it was the opioid use disorders that came first, and then pain developed at some point during that 10-year follow-up period. For another 15%, they had both chronic pain and opioid use disorders when they saw treatment at the clinic, and they couldn't determine what had come first. But for about 40% of those patients, it was the pain that came first, and then opioid use disorders developed secondarily. And for those people, that 40% who started with chronic pain, then went on to develop opioid use disorder, they tended to have also higher rates of mental disorders, other health conditions. And on the other hand, the patients who started with opioid use disorder essentially had more severe substance use disorders, right? Other substance use disorders, also things like HIV and hepatitis C. So interesting study. So take home point being, this is very common. Chronic pain and opioid use disorders often go hand in hand. And very often it's the opioid use disorders that come, or rather the chronic pain that comes first before the opioid use disorders develop. Now we're going to hone in a little bit on acute pain management. And all of this this is all artwork done by individuals with pain. This is public domain. And I have not violated any patient confidentiality here. These are individuals who have shared this art with them. So we'll start with a vignette. AN, 45-year-old female, after a shoulder surgery, has a history of opioid use disorder and has been treated in the past with methadone 2 times, but stopped treatment and returned to using heroin both times. And right before the surgery, she had been using about a half gram of heroin smoked about 2 or 3 times a day. And now after the surgery, she is on morphine continuous infusion, 4.2 milligrams per hour, plus 10 milligram IV per hour as needed for breakthrough pain. And she last used it 2 hours ago, so she's not due for that bolus again for a couple more hours, but she is requesting more pain medication and reports that her pain is 9 out of 10. She's in tears, her vital signs are stable. And when I get to the unit, we're told she's drug seeking, she's already getting more pain meds than any other patient on the unit. She doesn't need more. Besides, she's an addict and we don't want to worsen their addiction. So let's start with this and delve into this. So some commonly held beliefs, according to at least a couple of studies, is that, we know that acute pain, for example, is frequently undertreated in population at large, up to 60% in inpatient settings, but this tends to be even more so in patients with a history of addictions with substance use disorders. And it's been shown that addiction is seen by healthcare professionals as primarily a social problem that requires law enforcement rather than a health problem that requires prevention and treatment, right? And the patients with substance use disorders are often seen as manipulative. This is a literature, this is a graph that comes from nursing literature, because interestingly and importantly, it's the nursing literature that has really paid attention to this topic. Here, essentially, it's showing is that there may be, some prejudice, some underlying implicit biases, prior negative experiences with people with substance use disorders, lack of formal training. That's been shown a lot. That people they go through their professional training, they just don't learn enough about substance use disorders or about pain management, right? Also, all the media attention, all those things come together to misconceptions, right, about how to treat individuals with opioid use disorders who also have acute pain, which may lead to under medication of patient, leading to unrelieved pain, which in turn has a number of adverse consequences, including actually that pain may be going on to become more chronic, things like depression, anxiety, social isolation, also further mistrust of the healthcare system. So a number of bad things can happen if we don't treat that acute pain appropriately, right? So that's kind of really highlighting the need for appropriate management of acute pain, even in individuals with opioid use disorders. So what's the suggested approach? Start with accept the patient's self-reported pain. Keep in mind that pain behaviors vary widely. So we can't accurately, people don't express them the same, right? There might be gender differences. There might be cultural differences. There might be differences based upon prior experiences. And vital signs, although we often focus them, are actually not super reliable as an indicator of pain intensity. So we can't just rely on those. Consider, if you're treating these patients, addiction versus pseudo-addiction versus physiologic dependence, right? Addiction, substance use disorders as defined by the DSM-5 and by American Society of Addiction Medicine is a primary chronic disease of brain circuitry, motivation, and reward, right? Where the person has come to see that substance as being necessary for survival, right? They have cravings, their use has gotten out of control, the use has become compulsive. By contrast, pseudo-addiction is this idea that a person whose pain is actually undertreated may demonstrate behaviors that seem like they're quote unquote drug seeking, but in fact, they're acting in that way, they're displaying those behaviors because they're in pain. And simply providing adequate pain relief can take care of those behaviors and their functioning would go up. By contrast, someone with addiction, substance use disorder, simply increasing the dose of the medicine is not going to improve those behaviors, improve the functioning. Instead, what we often see is that functioning continues to decline. Physiologic dependence is essentially the person has built up tolerance to a particular medicine. So anyone who has taken many of our medications, right, not just opioids, but also, for example, stimulant laxatives, chronically will have developed that tolerance. And if it's withdrawn suddenly, they may go through withdrawals. So always think about those concepts and see what's going on. Is this actually addiction, or are some of these other factors at play? And if required, do not withhold opioid analgesics from people with addictions. And I'm talking about acute pain management. Remember, the principles are very different when we talk about chronic pain management. There is no data showing that acute pain management will worsen addiction. And so keep that in mind. Moving forward, now I'm gonna, also keep in mind that tolerance, patients with opioid use disorders already have that baseline tolerance. So it's not uncommon. In fact, it's expected that our patients with opioid use disorders will need higher doses of opioids than someone who doesn't have that baseline physiologic dependence, right? Like the patient in our vignette. She has a history of opioid use disorder. She has that baseline tolerance. So it's no surprise that she requires higher doses than what you might be accustomed to achieve that pain relief. And remember that opioid agonist treatment, right? The methadone, the buprenorphine, whatever the patient is on, will treat baseline addiction, but not acute pain. This is something that comes up for us a lot, where if one of our patients on methadone maintenance treatment goes into the hospital, requires pain management, and sometimes we hear, well, the patient's already on 80 or 90 or 100 milligrams of methadone. That's a pretty powerful opioid. Why should the patient need additional opioid analgesia? And the reality is that, remember, going back to the tolerance, that's the patient's baseline dose. So increasing the dose, rather that baseline dose is not going to lead to pain relief, and you have to provide additional analgesia. Now I'm going to zone in a couple of slides on methadone in acute pain management, and buprenorphine in acute pain management, and naltrexone in acute pain management, which are our three treatments for opioid use disorders. So starting with methadone. So if someone comes in to the hospital, requires acute pain management, these are the basic principles. Continue the baseline methadone after verifying the dose from the home clinic. Every person will have quote unquote a home opioid treatment program. You as a provider can call up that program and they'll tell you what the patient's dose is and when they last received that dose. If the dose cannot be verified, it's safer to break up the self-reported dose in 3 or 4 times a day dosing rather than giving it all at once. Makes it safe and actually makes it better in terms of analgesia. So for a couple of reasons, I think that's a better way to go. And you can additionally add in other short-acting opioids for breakthrough pain. Let's see, moving forward, those are some of the main principles of it. What about buprenorphine? So generally what we'll do for acute pain management with buprenorphine is you continue the buprenorphine very often, and you can augment with short-acting opioids, titrate up as needed. There's this common misbelief that it's just because someone is on buprenorphine, other full mu agonists will not be effective, but in fact they can be, and you can still augment buprenorphine with other short-acting opioids. Other recommended strategies that we temporarily may go up on the dose of buprenorphine by about 25%, split the dose up into 3 or 4 times the dosing, and then augment with either short-acting opioids or with non-opioid analgesics, right? So that's also often done. One strategy is to discontinue buprenorphine and switch to full mu agonists. But that's one we really try to avoid, because if we do switch a patient over to a full mu agonist, right, remember, we risk losing that patient. The patient may not come back to us for continuing buprenorphine treatment. So a lot of the acute pain we try to manage simply by modifying and adjusting the dose of buprenorphine and then augmenting, preferably with non-opioid analgesics, and if needed, with other opioids. Occasionally, for very severe pain, it may also be an option to switch from buprenorphine for methadone and augment with short-acting opioids. But again, that's a strategy we try to avoid because buprenorphine is just so much safer. And always think about use of non-opioid medications, epidurals, nerve blocks, etc. And if needed, consult a pain management specialist. What about naltrexone in acute pain management? This is going to be difficult because naltrexone is a very potent and powerful blocker at the mu-opioid receptor site, right? So one of the things we recommend is that if I have a patient on naltrexone, especially long-acting injectable naltrexone, I advise them to carry a patient alert card that informs medical personnel that they're taking the naltrexone, right? And generally, if it's elective surgery or if it's a mild acute pain management, if they're taking oral naltrexone, you want to provide that last dose of oral naltrexone 72 hours prior to the procedure. And if they're getting the injectable naltrexone, you want to make sure they get their most recent injection at least 4 weeks before the procedure. But if it's an emergency or a very severe pain need, then the name of the game really is multimodal analgesia, right? Including regional analgesia, use of non-opioid analgesics, and even things like conscious sedation or general anesthesia will often be required, right? So this is just a summary slide of how to do this for you guys. Now switching gears, and I'm just going to look at the time. We're doing okay with time. So that's acute pain management. I want to talk for a couple of minutes about chronic pain management. And again, this is another artwork by a patient with chronic pain and kind of feeling strangled by the cycle of the pain itself, as well as some of the medications for it. Some basic considerations. Remember, so first of all, very different. So for acute pain, one of the take-home points I was giving is that if someone with opioid use disorder has acute pain management needs, that those needs should be met. Acute pain management should be provided, right? Without really, certainly we should have in the backs of our minds worsening the substance use disorder, but acute pain management is reasonably safe. However, the principles are quite a bit different when we're talking about opioid use disorders and chronic pain. because history of opioid use disorders is the single biggest predictor of aberrant behaviors to prescribed opioids. So our patients who already have underlying opioid use disorder are very high risk for misusing any prescribed opioids for chronic pain. So for these patients, we actually recommend right away, even before starting opioids, if possible, consult a pain management specialist and use a multidisciplinary team approach. Use our non-opioid and adjuvant medications. Remember, there are many non-opioid medications that work for various types of pain syndromes, including our non-steroidal analgesics, our serotonergic, noradrenergic reuptake inhibitors, our tricyclic antidepressants, membrane stabilizing agents, as well as things like gabapentin and pregabalin. Also maximize our non-pharmacological therapies, right? There are many evidence-based therapies, including cognitive behavioral therapy for pain, acceptance and commitment therapy, things like yoga, meditation, pool therapy, acupuncture, traditional healing, physical therapy, as well as interventions such as nerve blocks, TENS unit, if needed, spinal cord stimulator, etc. So use a very comprehensive multidisciplinary approach. If you are going to prescribe opioids for these patients, right, there's a framework for responsible opioid prescribing. In fact, we do a different presentation where we delve into exactly this slide in a lot more detail. For responsible opioid prescribing, the framework includes being aware of individual risk factors. What are the risk factors that this particular individual displays that puts her or him at high risk for misusing opioids? Using validated screening tools. Believe it or not, there are a number of screening tools designed for people with chronic pain to assess their risk of misuse of prescribed opioids. One of the ones we like to use before starting opioid treatment is the SOAP-R, which is a validated tool. And for patients who are already on opioids, there is one called the Continuing Opioid Misuse Measure, or COMM, that we like to use. And if you do prescribe opioids, monitor them on an ongoing basis for any aberrant behaviors. The aberrant behaviors could look like the patient repeatedly running out of the medication early, or self-titrating the dose up, right? Or using other illicit substances, or maybe it can take the form of the patient using the medication to treat things other than the pain for which it was prescribed, such as depression or anxiety, saying, well, doc, I had a stressful day at work, so I took an extra tablet. Those are all aberrant behaviors, and we should be monitoring for them. We should be using universal precautions, including urine drug screens, PDMP monitoring, as well as treatment agreements. And we should always be prescribing naloxone. Anytime you prescribe an opioid, you should also be prescribing naloxone because it does save life and it's a great harm reduction modality. Now I'm gonna go into, again, a couple of slides on methadone, buprenorphine, in terms of how to manage chronic pain. So this is a vignette for methadone and chronic pain. This is based upon a real patient. All of these are, although I've changed potentially identifying details. 64-year-old female who came to the emergency department with dysuria. And when she came in, she was found to have advanced cervical carcinoma with local metastasis, and need for pain management was identified. There was concern about her 30-year history of heroin addiction and concerns about injection drug use. The emergency doctors and oncologists were frankly worried that she might inject right centrally if they sent her home. And patient at that point was started on methadone. So we started her on methadone for her opioid use disorder and carefully titrated it up, right? And the oncologists and the palliative care physicians placed her on short-acting opioids for breakthrough pain. And we worked very closely together, the oncologists and OTP physicians. She stayed with us actually for about 3 or 4 years and did very well. Did not have any further relapse onto illicit opioids, and received good care, and was quite proud of herself that she was able to achieve that sobriety towards the end of her life. So take-home point is that in some cases, patients' opioid dependence may be better treated with methadone maintenance, right? If the underlying pain management need is going to be so high. And this is usually the case in patients who have cancer-related pain or sometimes other very severe pain syndromes, right? Now a vignette on buprenorphine and chronic pain. So take-home point, barring the very severe pain syndromes, if a chronic pain, many of the chronic pain syndromes actually are very amenable to treatment with buprenorphine. So this is another vignette, a 55-year-old female who comes in for addictions treatment. Has a 12-year history of chronic pain after an ATV accident and pelvic fracture. And over time, she has built up to 300 morphine milligram equivalents a day. And there are aberrant behaviors. She runs out early and then buys them off the street. She goes to multiple doctors, and she reports problems in marriage, work, and relationships. And she also reports worsening depression and anxiety, stating, I have pain all over, and it's worse than ever. So we identified her as having underlying chronic pain along with opioid use disorder. And to treat both, we actually started her on Suboxone. 4 milligrams 3 times a day is what she was titrated up to. Did very well on that dose, reported improvements in pain, felt happier, was functioning better at work, and reported, quote, I have my life back, right? So if chronic opioid analgesics are required for pain control, buprenorphine is going to make it difficult because it's going to provide that strong blocking effect. So you may need to think about either methadone, or more often, it's what I've highlighted in red. A subset of patients, I would say many patients with chronic pain and a history of opioid abuse or opioid use disorder may experience reductions in pain and actually effective treatment of their underlying opioid use disorder and abuse liability with maintenance by buprenorphine naloxone, also known as Suboxone. Keep in mind that if you're using Suboxone to treat opioid use disorder and chronic pain, you should divide the daily dose into at least 3, possibly 4 times a day. There's also additionally increasing evidence that buprenorphine can actually help possibly mitigate opioid-induced hyperalgesia, which is this central sensitization we see in our patients who have chronically been on opioids, right? And this was a pretty classic study that shows that. So this study was done at a pain clinic where they took individuals with chronic pain who were on very high morphine milligram equivalent doses of multiple opioids. And you can see that the lower number that was 200, and many of these patients were on over 1,000 morphine milligram equivalents a day, very high doses, right? And they took all of these opioids and converted them to buprenorphine monotherapy and looked at their pain scale, the visual analog scale, before and 3 months after converting them to buprenorphine monotherapy. And you can see that even in the patients who were on the highest doses of opioids, there were pretty substantial and significant reductions in reported pain experience. So just switching over to buprenorphine, they actually felt better pain, and so they were not, we don't worry nearly as much about respiratory suppression or overdose or drug-drug interactions, things along those lines. So always keep buprenorphine in treating patients with opioid use disorders and chronic pain. Remember that sublingual forms are approved for treatment of chronic pain, but can be effective and commonly used. The buprenorphine patch, as well as a buccal formulation, actually, are both approved for treatment of chronic pain, severe enough to require daily around-the-clock opioid treatment. Finally, if someone has significant chronic pain, naltrexone is probably not a great option, because if you give them naltrexone, then you're not really able to provide them additional opioid-related analgesia. So for patients with opioid use disorders and chronic pain, buprenorphine really is the main option. Methadone may also be a good option in certain selected patients with severe pain conditions. So I will end here. It is 12:29, so I'm keeping myself on time.